on the computer. Okay, excellent. Okay, well, welcome everybody to this, our first event on Justin's campaign. Justin Paglino is running in Connecticut's 3rd District for the House Representative seat that's currently held by Rosa DeLauro. We're seeking the Green Party nomination for the 2022 election. And tonight's topic of discussion is Medicare for All, the federal bill that was introduced in Congress last week by Pramila Jayapal and has already been co-signed by or co-sponsored by majority of the Democratic Party, which is really cool. But we are going to talk about it here, how it relates to this district, how it relates to Justin's campaign, and more importantly, how it relates to all of us on this call. So with that, I'm just going to ask people to please, keep yourself on mute until we get to the Q&A part. And if you do have any questions throughout the presentation, please drop them in the chat and I'll be sure to ask them during the Q&A part. If you just want to drop your name in the chat, where you're from and what brings you to tonight's call, we'd love to be introduced to you. So with that said, I'd love to welcome everybody to Justin Paglino, who we are all here to see tonight. And so with that, Justin, why don't you take it away?
All right, thank you, Sivan, for helping and arranging this event and everything. I have a brief presentation to share, very brief. Let's see, I think I want this one. Okay, so yeah, I am Justin Paglino. I live in Guilford, and it's good to see you all here. Thanks for coming. I ran for Congress last year, and I'm running again in 2022 for the 3rd Congressional District seat. First and foremost, because I believe we need Medicare for all, and we're going to talk about that tonight, what that is. And I'm very thankful to Justin Halloran, who's here. He's a medical student from Yale, and he is a member of Physicians for National Healthcare program. He's going to present some more the detailed information about Medicare for All that some people are interested in. And I don't want to steal any of your thunder, Justin, but I'm just going to present just some of the brief major points that I think are important, and why I'm such a passionate supporter of Medicare for All. Well, how are we doing with our current healthcare system? 6% of Americans say it's fine just the way it is. So that could be worse, but it's already quite low. I think obviously there's a widespread recognition that we have a failing healthcare system, despite some who say, oh, we have the best healthcare system in the country. But what are the problems? Well, medical costs are, if you ask people and do surveys, medical costs are causing hardships for more than half of all Americans. And an amazing fraction of people are going without the health care they need simply because it's unaffordable. Some say 1 in 4, some estimates are up to 1 in 3, that people are just not able to get the care they need. It's simply unaffordable. Our system is the most expensive in the world per capita in terms of what is spent. And it's about twice the average of other wealthy countries. On the other hand, if we were to switch to Medicare for All, by which we mean a single payer universal healthcare system where all bills are paid by the federal government and patients still have the freedom to go to any physician they choose, this would save us, some estimates, $450 billion. The CBO, Congressional Budget Office, has estimated over $600 billion that it would save us every year. This would be the best way to bring down the cost of healthcare in our country. Very effective. And on top of that, because now we're covering everyone and there's no financial impediment to getting healthcare at all, it's estimated we would prevent maybe 70,000 unnecessary deaths every year. So saving money and saving lives, these are two great reasons that I think to support Medicare for All. And a lot of Americans are convinced by the arguments. In some polls, 70% of registered voters support Medicare for All. However, and in the House, there's legislation, but it's 118 co-sponsors, which out of 435 members is not a majority, and it's a slight majority of Democrats. So what's the problem? What's the holdup? Well, here's the current bill. We're celebrating, so to speak, the introduction of Medicare for All. I mean, at least it's a bill now in Congress. I mean, it has been a bill for many years, but there are still people fighting for it, pushing for it. This new bill is called HR 1976, so keep your eyes out for it. Maybe set a Google alert. But my fear is that, unfortunately, not much is going to happen because even though it has 100, right now this bill has 112 co-sponsors. The bill from the previous Congress had 118. The leadership of the Democratic Party has the power to decide what bills get voted on and what bills don't. And Nancy Pelosi does not support this bill. And you know, she does have a challenger, Shahid Buttar. So people in her district can do something to try and replace her because she just doesn't support this. If they want Medicare for All, they need a different leader. They need a different Speaker of the House. But what we can do in our district here is to replace our representative who does not support Medicare for All either. And you know that her name is Rosa DeLauro, and she has positive features to speak of in her favor, but she does not support Medicare for All. She simply just, she won't do it. She won't co-sponsor it. And she's been in office 30 years and she's had plenty of time to think about it. And that's where she stands, and that's where she's going to continue to stand. As far as I can tell, I really don't hold out any hope for any change there myself. So that's why I'm running. That's why I'm doing this, is so that people can know that there's a candidate on the ballot who supports this, and they can vote for it because people are dying and people are not able to afford the healthcare they need, and it's a moral outrage. And if you can't vote for something, you'll never get it. Or put another way, if you want something, you have to vote for it. You can't just vote for the lesser of two evils and go home and hope you're going to get Medicare for All, at least not in our district, because in our district, the lesser of two evils doesn't support Medicare for All. So your vote just won't, it'll count for something, but it won't count towards Medicare for All at all if you vote for Rosa DeLauro, unfortunately. So that gets to the reason why I think we need more than two parties. We need ranked choice voting in a multi-party system so that we can have a more representative Congress. So this is what I'm doing to try and be part of the solution if I can. And I'll stop there and say thank you to Justin and let you go into your talk.
Sounds great. Thank you, Justin. So let me just share my screen. I can pull out the PowerPoint. So just bear with me for 1 second. Okay, everyone able to see it okay?
Yep.
Okay, great. So as Justin said, I'm Justin Halloran. Like I said, we're just trying to be as confusing as possible. I'm a 4th-year medical student, but I'm doing an extra research year in psychiatry. So I'll be here until 2022. But I have finished my clinical part of my training in med school. And I do want to give credit, by the way, that the original presentation materials I'm using were by Dr. Weisbart, who works with the Physicians for a National Health Program group in Missouri. And so I want to give a little bit of an explanation of how I got involved with this. As Justin mentioned, I work with Physicians for a National Health Program Connecticut, And I also helped start the chapter of Students for a National Health Program at Yale, which is a group of medical and other health professional students that are invested in the same thing. And so I originally got thinking about this issue long before I ever thought about going to med school. When I was in high school, experiencing the loss of health insurance by my mom, previously on my dad's union insurance, and then no longer covered. There were a few years where it was a significant point of anxiety for me, wondering how my mom would access healthcare. And then in terms of professional experiences, I have seen the same thing play out over and over again, despite the fact that I haven't been in medicine for very long. The story that stands out in my mind that I always bring to conversations about this were on my first medicine rotation at Bridgeport Hospital. A patient had been brought in with type 1 diabetes. For those of you unfamiliar with the types of diabetes, that type 1 diabetes often happens in younger people, and it involves an autoimmune attack of the cells in your body that make insulin, which means people with type 1 diabetes often have to buy insulin, which is a fairly expensive medication. So this patient had been brought in because she wasn't taking her medication as prescribed. And the team spoke with her for about 5-10 minutes, kind of scolding her for not taking her medication as prescribed, for not following directions. And after everyone else filed out, I stopped and said, are you having any trouble affording your medication? And she said, well, I work part-time at a grocery store. How could I possibly afford my insulin? Of course, I'm not taking this prescribed. And I think I bring this story partially because it shows that it happens with anyone. This person was younger than me. In theory, she was in an age where she would have been covered by Obamacare under her parents' insurance, if her parents were insured, just like I was covered under my dad's union insurance up until I was 26. But unfortunately, she wasn't, and she couldn't access the healthcare she needed despite being in her early 20s, which to me is long before most people should be expected to be making life-saving decisions with their jobs and their health insurance. So that's essentially two of the stories I like to bring up in terms of how I got initially involved with this. And as I also mentioned, I then started the chapter at Yale. And so I've been having conversations with other medical students, both at Yale and around the country on this topic since. So Justin went into a little bit of why our current system needs to be changed. It's fairly unpopular, despite the fact that some people will tell you that it's the greatest healthcare system in the world. But to get started, let's compare it to other nations' healthcare systems in terms of how we pay for it. So common finance models, we have something like the National Health Service, for example. The UK is probably the most famous example of this. What this means is that you have taxpayer dollars that go towards a publicly delivered healthcare system, meaning the government employs doctors using taxpayer funds to deliver healthcare. And so you could call that socialized medicine because the insurance and the doctors are both part of the government. What we're proposing is called a national health insurance. We call it Medicare For All in the US often. It's publicly funded, meaning it comes from your tax dollars, but it's delivered by private agents like doctors and other providers. So you can see this with something like Canada, for example, where it's private doctors employed by themselves, but they get paid by the government. We also have something called the Bismarck Plan, originated in Germany. It's a mixed funding, but it's delivered mostly by private providers. So the government, employers, and patients all sort of chip in for these nonprofit insurance plans. They're often done via employment, but you can also get subsidies if you don't have a job in Germany, for example, to get this insurance. So we could get to something closer to this by expanding on Obamacare, but we'll go into a little bit of why it isn't necessarily a great solution either. And then lastly, we have the US, which is kind of in a league of its own. We have mixed fundings. We have a lot of dollars coming from taxpayer funds, a lot of dollars coming from private contributions from you or your employer. And it's delivered in both public and private healthcare settings. So for example, the VA or the Indian Health Service, which are public settings, as well as private doctors that many of us would go to. And so I think it is kind of clear here, but we'll go into a little more detail in terms of how the US healthcare system is really very confusing and also not necessarily cost effective at what we're trying to do. So looking at how many people are covered, you can see that the US fares pretty poorly compared to our peer nations. Pretty much everyone is covered under these other systems. For example, the National Health Service, anyone can walk into the National Health Service hospital and get care, even though many choose to get their healthcare in the private sector as well. And then the same thing goes for these other countries. Pretty much everyone is covered unless there are, for example, lapses in your coverage in between jobs, that kind of thing with the case of Germany. But you can see that the US pretty much consistently ranks around 85%. This is actually data from 2017, which was after several years of improved coverage after Obamacare was passed. And during the past 4 years, we've actually had decreases in coverage. So this actually might not be as bad as it is currently, unfortunately. Thinking about how we actually pay for our healthcare, we want to be thinking about how many doctors we have to provide that healthcare. If you look at other countries, they have a lot of primary care doctors compared to the US. And the reason I bring up primary care in particular is because primary care accounts for about half of the interactions with the healthcare system that we have. It's only 5% of the cost of our system, but about 50% of the interactions with the healthcare system. And the reason it's good to have a lot of primary care is because it often keeps people from needing specialized care. Either you can handle someone's complaints in the office rather than needing to have them go to a specialist, or you prevent problems from becoming worse by having consistent follow-up. And so that's why we have a very expensive system that doesn't provide primary care as well as other countries. It's also worth mentioning that while this measures primary care physicians, we also have nurse practitioners and PAs that provide healthcare, which aren't as common in other countries. So we might have some primary care providers that aren't mentioned in this chart. But the point still stands that we don't prioritize primary care very well. And how does this lead to our actual results? We unfortunately have much lower life expectancy compared to our peer nations. You can see of the countries listed here, we're at the bottom at 81 years old for women. And you can see that that disparity holds true for men as well. The US does not do well when it comes to life expectancy. A common concern with this is, well, is this caused by other factors? Are we smoking more? Do we drink more? Are we, for example, do we have different levels of obesity in our country? And we'll come back to some other charts that show that those unfortunately do not explain all of this. And as Justin mentioned, we also want to think about how much we're spending. Are we getting what we pay for? You can see how much these other countries spend per person, and that's per person in the entire country, not just per person covered, because pretty much everyone there is covered. Here you can see that we spend about 8,000, and I think as Justin's chart showed, that has actually increased in the past couple of years, so now might be closer to 10,000 per person in the US, despite only covering 85% of the population. So long story short, we have many better choices on how we could actually finance our healthcare. Whereas ours, we have the most expensive system in the world. About 20% of our GDP goes towards healthcare. The closest second is Canada, with 11% of their GDP going to healthcare. And with Canada's system, they have better life expectancy and everyone covered under their system. So just, broad terms, you can see that we are not really getting what we're paying for. If we look at administrative costs, we might think that this is one area where the US would do better, because you have a private sector system. We have people with a profit incentive to trim the fat, try and get rid of any bloat in the system, any bureaucratic red tape. And you can kind of see by the scale in this chart, that is not going to be the case. We spend $863 per person in Canada on administration of healthcare, and over $3,000 in the US. And what that essentially means is that every American is paying on average $2,500 or so just to administer the healthcare system in the US that we don't need to pay for. That in theory, if we were under the Canadian system, we would not be paying for it, and that money would either be in our own pockets or going towards our healthcare. And so just to sum up, Canadians now spend about half as much, have fewer unmet health needs, and live 3 years longer. One stat I heard in med school that I thought was pretty shocking is that we actually spend as much of our GDP on government-funded healthcare as Canada does, despite the fact that they cover everyone with their public spending. And so I think that just frames how much we're spending on healthcare in the US and how little we're getting for it. So we keep talking about Medicare for All, and I think a lot of people don't necessarily understand why we're choosing Medicare as a model and also how Medicare differs from other systems. So I just want to get some definitions in place. Medicare, as many of you might know, it's a federally funded program. It covers Americans age 65 plus, also Americans with chronic kidney disease and some disabilities. Medicaid is different. It's also called Husky in Connecticut. It's a federal and state co-funded program, covers low-income Americans and some other specific groups, for example, pregnant women. In Connecticut, the Children's Health Insurance Program for low-income children is also rolled into Husky, and so that other states may or may not combine it with their Medicaid programs. But Husky is fairly well liked in Connecticut, and so that's one reason I wanted to mention it here. We're going with Medicare for a few reasons I'll go into. One, Medicare has a fairly high approval rating. You can see here, it's comparable to the top most satisfied group of Americans. Military or veterans tend to be the most satisfied, whereas Medicare is a close second. 77% of people are satisfied with the way the healthcare system is working. You can see Medicaid is fairly close behind at 75%, even higher than union healthcare plans or employer-based health plans. And as we can all imagine, uninsured people are very dissatisfied with the way the healthcare system is taking care of them. 2, it's affordable. We talked a little bit about administrative costs. This chart specifically shows overhead. That's essentially all of the money that's not going towards your healthcare when you pay for an insurance plan. So that might include overhead for the administrative costs. It might include profits for the insurance company. And so you can see all these prominent insurance plans, over 10% of that money for each of them is going towards either in their pockets or going towards administering the plan. If you compare that to Medicare, parts A and B, which cover physician and hospital services, you can see it's only 2.3%, meaning about 98% of the money going towards Medicare is actually paying for healthcare, not going into bureaucratic red tape, not going into profits. Actually delivering healthcare is the vast majority of where the Medicare dollars go. In terms of health outcomes, we want to compare the US to other countries again. This is the rank when compared to 16 other countries. You can see on the bottom here which countries are included. So we have countries like Australia, Canada, the UK, Japan, France. And you can see that of those countries, the US ranks along the bottom for pretty much every age group. This is controlled for factors like obesity, income, age, insurance, race, and tobacco and alcohol use. And when I see the insurance status being controlled for, that means that this includes many people who are insured under our system. And what happens when they hit age 65? You can see that our rank compared to our peer nations shoots up. And this is due to a number of factors. But really, I think the most prominent one is that Medicare is a program that is designed to prioritize health, not profits. And when you have a plan like that, there's no incentive for them to withhold healthcare that you might need in order to preserve their bottom line. We also, because of that, have really good healthcare for certain conditions that often affect us at the end of life. For example, cancer care, which isn't impeded by the fact that many people receiving that care on Medicare. And this chart just shows how complicated our current system is compared to what we're looking for. So healthcare consumers pay towards their private healthcare plans. They also pay taxes towards the US and state and municipal governments, which are involved in paying for healthcare, as well as employers. And so many people have their money involved in this plan. Whereas the system that we would be looking for is just healthcare consumers paying taxes. Those taxes are used to pay doctors and hospitals directly for services. The fact that no one can really explain the healthcare system, to me, is a problem with our healthcare system. I think we should have a plan that people can understand and actually be able to navigate. So why do we call it improved Medicare for all as opposed to just Medicare for all, which is the usual shorthand? One of them is that Medicare doesn't always provide all the care that we need. And so if you have everyone enrolled under the same plan, what we'd like to do is take this opportunity to shore up Medicare and make sure that it's providing all the care we need. So what does that mean? It means prescription drugs being covered fully, eyeglasses, dental care, hearing aids, and long-term care. Long-term care includes things like home-based care, as well as retirement homes and nursing homes. Those aren't typically covered under Medicare as it stands. People often have to spend down their assets until they're eligible for coverage under Medicaid, which means that people near the end of their life are spending down a lot of the money that they've worked hard their whole life to save in order to actually receive the services they need. It's funded like other public services, for example, the library. So when people get into topics like, is healthcare right? Sometimes I kind of think that it's dancing around what we're really saying, which is we should be providing this to everyone, whether you call it a right or whether you don't call it a right. We're better off if we provide this service to not only ourselves, but also our neighbors, our friends, our family. And so I think of it kind of like a library where even if I don't have a right to a book, it's great that we have these available to us. And it's great that we can take advantage of this. Healthcare to me should be even more essential. When we say it's like other public services like the library, what we also mean is that there are no copays, deductibles, premiums, and if you don't want any supplements, you don't have to get them. So it's free at the point of receiving healthcare. It's not free because we're paying our taxes along with everyone else, but we are receiving the services free when we go. So there's no disincentive to receiving healthcare that you need. It also includes everyone on the same plan. So it's different than Medicare as it stands right now, where you might not be on Medicare, or you might be on one of the privately administered Medicare plans, or you might be on a private health insurance plan before you're old enough to be on Medicare. What that means is that doctors and hospitals under our current system can choose which insurance plans they want to take, but under a Medicare for All system, they would all be incentivized to take the group plan that everyone is a part of. So that'll give you greater choice of your doctors and hospitals than you would get under our current system. Congress would also be on the same plan that we do, so there'd be an incentive from our stakeholders to make the plan good and actually provide services that they would want to get. And private plans that exist only to supplement the public plan. So for example, if you want cosmetic surgeries that aren't considered essential by your provider, if you want designer eyeglasses, those are the kinds of things you would go to your supplement for. Private insurance companies would still exist, but they would kind of be relegated towards that role. In terms of how hospitals are funded, it would also be a little bit different under a Medicare for All system. We'd have something called global operating budgets, similar to how the VA is funded. So under hospital financing today, what we have is a system in which hospitals prioritize procedures and billing in order to get as much money as they can from the patients who are coming in. What that means is that they have an incentive to push procedures or certain types of healthcare that are lucrative, but not necessarily high value for the patients. That's one of the reasons that primary care providers in the US are not compensated very well, despite providing very high value care, whereas proceduralists end up earning a lot of money. And many medical students don't go into primary care because they know that the incentives are not aligned towards providing that type of healthcare. In addition, when you have something like a pandemic where all of a sudden patients aren't coming in and receiving things like elective surgeries, well, then you have a huge shortfall in funding that hospitals may or may not be able to wait out. Many rural hospitals or hospitals in low-income areas weren't able to survive COVID because they didn't have something like a global operating budget. So under Medicare for All, you have a global budget. The government takes a look at each hospital and decides how much it needs to actually run for the next year, taking into account the health status of that population that they're taking care of, as well as what kinds of services are needed in that area. It ends the hunt for the most profitable interventions and aligns incentives more towards the health of the patients. And it really reduces hospital administrative overhead. If you think about how much of the hospital is devoted towards actually billing, making sure that all of our patient notes include everything that are required to actually get billed by the insurance company. You have a huge machine that is devoted just towards getting as much money as you can out of the system. If you have a system that is not centered around that, you can end up actually streamlining it significantly. And this is a collection of different studies. I know Justin mentioned a study by Dr. Galvani out of Yale, who's an epidemiologist, and she also found that Medicare for All would save money, but this review predates her study coming out. So you can see 22 studies, almost all of them showing that we would end up saving money in the long run. Some of the few that show that we would actually end up spending a little bit more were, for example, the Vermont plan, which is on a much smaller scale and a very specific setting like Vermont, where there aren't a high concentration of providers, where you have a somewhat low income state trying to chip in and cover this on a small scale. When you have a program like Medicare that's already established and can easily enroll more people, you end up having to set out less money to actually establish a plan like that. So I really don't think these studies over on the left are necessarily indicative of the money that we would stand to gain by switching to a single payer plan. And how are we actually saving that money? We're going to be covering more people, so one might think that we'd be spending more money. And you're right, we would have 12% increase in new expenses because we're delivering different types of healthcare we weren't before, and we're covering more people. We also get savings in administrative costs, savings in pharmaceutical pricing, because now we have one cohesive healthcare plan that can negotiate drug costs with the pharmaceutical companies. We can come back to that during the Q&A, since that's often a topic people want to discuss in more detail. We also have uniform rates on delivery. Under our current system, different health insurance programs are charged different amounts of money by each hospital, and they aren't allowed to share how much they're paying for each service. And so what you have is a huge black box in terms of how much insurance companies are paying. And you end up having insurance companies pay more just because they weren't able to negotiate a better rate. So we could save money just by paying one consistent amount. And lastly, you get to cut down on fraud and waste because you have one system it's much easier to find any irregularities in billing when you have one system, so you can cut down on things like this. So now some of the bad news. Unfortunately, we have a huge healthcare system that is designed around this for-profit insurance industry. What that means is that many people are employed by this system. So if you overhaul the system, how do you make sure that we're still taking care of those people and not leaving them by the wayside? There's going to be some displacement by Medicare for All system. For example, many private health insurance employees, the administrative staff in hospitals and physician offices that are involved in working through this labyrinth that we've kind of set up in terms of insurance. And so the total worst case scenario is 1.7 million people, which is significant. So how are we going to address this problem? It's mitigated by income protection and job retraining, which you can see is mentioned specifically in the bill released this past week. We have precedent for this with veterans returning home from World War II, where they received income protection and also funding for education and retraining in different jobs. And that's funded in the bill as it stands. Many would also likely be employed in the expanded clinical workforce, for example, retirement homes and nursing homes that can now take more people, as well as other types of healthcare that would have to be expanded. In addition, Medicare contracts out a lot of its administrative work towards insurance companies. So while insurance companies might have less of a role than they do right now, they would still essentially be working as Medicare contractors, not running their own plan, but doing some of the legwork for Medicare. In addition, a Medicare for All plan, by allowing more people to seek healthcare, spend less on out-of-pocket costs, it stimulates the rest of the economy, and so we'd expect some job growth to result from that as well. So the total job loss would be less than one might expect just looking at the insurance industry individually. And so now coming a little bit to the provider perspective, why do most physicians want Medicare for All, or in my case, a medical student, soon to be a physician? Most recent studies find that physicians are generally supportive. That's a recent change. I think as of 2016 is when it flipped over towards most physicians being supportive. And so part of that is because of how the healthcare system as it stands is showing the cracks in it and how it's not working very well. So let's talk about why. US physician satisfaction is low, especially if you look at primary care providers, which, as we mentioned, provide a lot of the healthcare that we get. Only about 2/3 of them are satisfied practicing in the US healthcare system. You can see that many of our peer nations do much better on this front. And why is that? Again, just showing here that Canadian physicians, in contrast with a few decades ago, are not leaving the US or leaving Canada en masse to come to the US and practice healthcare here. In fact, the opposite is happening, that most of them are going back to Canada to practice medicine. So what's the problem with the US healthcare system? A lot of it is how little time we actually spend with patients and how much of it is spent on other aspects of the healthcare system. Only a quarter of our time is actually spent working with patients. If you look at something like residency training, which I'll be entering in the next few years, it's actually even worse. About 1/8 of the time for a medical trainee is spent dealing with patients directly. About, in the case of a primary doc, about half of it is spent just doing note writing and desk work, which includes dealing with insurance companies. That excludes time at home, which is about 1 to 2 hours per night of additional administrative work. And so you can see that this time adds up to not only time spent doing something that's unfulfilling, but also time spent not doing what we actually are paying for doctors to do, which is to provide effective healthcare. Another point that I often am asked, both by physicians and also by non-physicians, is how do we encourage physicians to stay in healthcare if we're most likely going to be paying them less by a publicly run insurance system? And that's true. There would be a cost incurred by physicians switching over to this plan. While it might be balanced out by better work-life balance and more fulfilling work, they would end up earning less. And so Senator Warren's Medicare for All plan, which I believe is very similar to the one being proposed currently, although I don't have an estimate on the new one currently if there are any significant changes. Physicians' compensation is reduced by about 6.5%. Notably, some physicians would see an increase in earnings, especially primary care providers, but you might have some proceduralists, surgeons, specialists earning a little bit less money. And so the average is about 6.5%. What that means is that the average doctor would end up earning, rather than a little bit over 300K per year, earning a little bit less than 300K per year. So as someone who recently entered this field, it quite frankly does not seem like a deal breaker. As it stands, about half of people who apply to medical school don't get in. And essentially we have much more demand for jobs in healthcare than we actually have supply. So I don't think disincentivizing physicians from entering the workforce is really something that we should be worried about when switching to a plan like this. And obviously a huge topic, and I'm going to try and address the public option in one slide, because I think a more lengthy breakdown to this is beyond the scope of the talk. But there are some merits and some challenges to the public option that I think make it not worthwhile to pursue. So the merits, you have an additional choice of health insurance. Rather than forcing everyone to be on the same plan, you have one additional option that people can avail themselves of, which seems appealing. I think most people would like to think that people are in control of your healthcare decisions. And while I think that corresponds more to the healthcare you're receiving, many people feel that's true of the healthcare plan itself, or who's in charge of their money. And what this means is it applies free market principles. People can vote with their feet and go towards any plan that they think is best. So that's appealing for people who might think that competition is the way to drive innovation and best services. It's also less disruptive to the insurance industry, so you wouldn't have to worry as much about transitioning people off of their jobs, especially in the administrative sector. It's also easier politically than Medicare for All, as you can imagine. But there are some reasons I think that we should really be pursuing single payer as opposed to this public option. First thing is that it's complex. It's one more choice in a system that's already incredibly complicated. Many people can't navigate the system as it stands, and now you're potentially creating another layer to this. And what that means is that it fails to relieve any of the administrative burdens and costs associated with our current system, which means you don't really have any cost savings with introducing a public option the way you would with single payer. You also run the risk of a two-tiered healthcare system. If everyone who can't afford the private healthcare system is going towards the public option, then what that means is that the private sector is going to cater more towards high-paying patrons, which means you're going to have one system that works really well for some people and one that doesn't really have as much money to function well for others. Along with that, private insurers know how to turn a public option into a high-risk pool. What that means is that insurers would advertise towards people who are earning a lot of money, people who are healthy, people who are highly educated and very literate when it comes to their health, and encourage other people to go towards the public option by disincentivizing them to come to the private sector. What that means is that the public option would be getting very little in the form of premiums, but end up paying a lot of money out because people end up needing the healthcare when they enroll. This is essentially how the private insurance industry started. Originally, our insurance industry was nonprofit until for-profit insurers figured out how to recruit healthy and affordable members towards their plans. And so we don't want to replicate that with a public option. This is essentially what's happening with Medicare already, in that private for-profit healthcare companies are incentivized to delay healthcare and push it more towards people once they age into Medicare. And lastly, many will remain uninsured. Congressional Budget Office doesn't actually estimate a huge gain in people being insured with the public option because it's still expensive and there's still huge cost sharing. So even if you're on the public option, you might not be able to afford the healthcare you need because it might not be as robust and you might need to pay more in copays and deductibles. And so essentially you're not getting most of the gains we're hoping to get with the single payer plan. This, we just want to end on discussion of values. All of us, regardless of what plan you're hoping to propose or push for to get everyone covered, we all are looking for affordable access to healthcare because we all know that it allows you to pursue your goals, both in terms of your career, your family goals, and essentially what we all think of as the American dream. So whether we think that's through a single payer system or a public option, I think we're all here to have a respectful discussion about what system is going to provide that the best. And so with that, I just want to end on showing the PNHP website, which has more detailed answers to many of the questions that people have. For example, how are we going to address things like wait lists? Will this stifle research, especially in pharmaceuticals? And will politicians run healthcare? Obviously, this is a huge topic, and so it's not really feasible for me to cover it within a 20-minute discussion, but hopefully we can talk during the Q&A about specific questions you guys have had. I see the chat's been going while I've been talking, so hopefully we'll have a lot to talk about. And Justin, thanks again so much for inviting me to talk.
Thank you so much, Justin. That was fantastic. I find, you know, the data when it's presented like this to be incredibly persuasive. That it's just that Medicare for All is really the most logical solution to all the inequities we face, all the people not getting healthcare and the costs being unaffordable. It just makes sense top to bottom to me. and I think to most people. So we have a political problem of our Congress not supporting it. It's part of why I'm here. But I think it's a very compelling case. But why don't we go ahead and open it up to questions? Thank you, Justin.
Yes, Justin, thank you. That was incredibly in-depth and informative. And I think everyone came up with some really great questions as well, which we'll get to in a second. But I just wanted to drop in the chat some helpful links for people. So Justin Paglino's website, if you'd like to sign up to our emails, to our newsletters, you can do so on the website here that I'm putting in the chat, and please go ahead and do that now. And then here is also the Physicians for a National Health Plan, which Justin Halloran and Justin Paglino are both members of. And you can sign up for their newsletters and other, sign up to volunteer with them as well. And then we're here tonight to help raise funds for Justin's campaign in order to send him to Congress to be a representative to vote on this, to be one of the 112, or he would be the 113th, I guess, co-signer of this bill. And our competitor, our opponent, Rosa DeLauro, has a war chest. She raised over $2 million last campaign. And guess who her #1 donors were? From the healthcare industry. So that's what we're up against, but a people-powered campaign like our own is what is going to get us to Congress and hopefully scare the bejesuses out of her. I also learned over the weekend that her husband works for Monsanto, which is giving us all cancer, so we have to go to the hospital. So it's, one hand feeding the other. So that being said, if everyone now can take out their wallet and follow the link in the chat here. We have a suggested donation tonight of $10. If everyone donates $10, we will hit our goal for this evening. So please go ahead and donate there. If you don't like putting information over the internet or anything like that, here's our mailing address. We accept checks and money orders and everything. So that's our PO box right there. So sorry, had to get that out of the way. We do not accept a penny from corporate donations or anything like that. I would not be Justin's campaign manager if he did. So yeah, just like Justin said, if you want something done, you have to vote for it. And unfortunately, we also have to vote with our wallets. So please go ahead and make those donations. And with that, why don't we get into some of these amazing questions? I was scared we were going to have a shy audience, but we're very, very active audience. And thank you everybody for these wonderful questions. So from Brian wants to know what Dr. Paglino's thoughts are on the public option. And specifically to Connecticut, there's currently a proposed legislation within the Connecticut General Assembly to expand the state employee health care plan to include non-state employees, but that it should be clarified that if you're working for a small business or a nonprofit, so it's not it wouldn't be available to just anybody, and so that is being called a public option bill. Also, Connecticut Senator Chris Murphy advocates what he calls Medicare for All who want it, which differs from Medicare for All in that it maintains the private health insurance system alongside the expanded Medicare and Medicaid systems. So Brian is interested to hear your thoughts on these proposals as they relate to the plan that you support and how you think they would help or hurt the current healthcare system, including for consumers and providers.
Yes, well, I think, Justin did a great job of kind of covering some of the main concerns with the public option. It sounds like, better than doing nothing. And it may, in some ways, if it expands coverage and more people are getting healthcare, that's the goal. But it doesn't solve the financial problems, the enormous cost of healthcare. It really doesn't. And in some ways, it could lead to this issue of pooling people into a high risk pool, or people who can't afford to buy the higher end insurance being pooled into the more affordable but still unaffordable for many public option. And it would still have cost sharing, so there still would be co-pays. I think we would, I think with Obamacare, which was not a public option but was more of a federal subsidizing of private insurance, we were hoping for some improvements, but the cost of healthcare has continued to increase. The biggest thing that, really the biggest help that seemed to come out of Obamacare was the increased funding for Medicaid programs for the states that took it, and that really expanded coverage to a lot more people. But with Obamacare, we saw the number of uninsured drop, and now it's creeping up again. It's heading back in the wrong direction. And I think with a public option, we'd kind of see the same thing. We'd see kind of some improvement, but we'd see really persistent lingering of prominent problems, like still a lot of people who can't afford healthcare, and still having the highest costs in the world for healthcare. So I think it's just kicking the can down the road, and that's why I'm fighting for single payer. Justin, you have thoughts on that?
Yeah, no, I think you summarized my points very well. I think it's also fair to say that we're already kind of seeing what this looks like if we have a public option that isn't sufficient. Many of the Obamacare plans, especially the bronze plans, have very high deductibles. And so while someone might be able to advertise that they supported Obamacare and now people are covered because of it, some of that coverage isn't really sufficient because, for example, if you have a $6,000 deductible, meaning you have to spend $6,000 to access the healthcare that you got off of the exchanges, I mean, to me, that doesn't really sound like insurance at all, because you can't use it for most of the things you would actually want to. There's more to it. I think some of the Obamacare plans that I mentioned still cover certain services, but essentially what I think we don't want is to put people in a system where we're saying that we're taking care of them, but because they are sort of the other, or people that other people think are getting charity, there's a disincentive to providing robust services. If you have everyone on the same plan, then everyone has some skin in the game and everyone has an incentive to make sure we keep these programs functioning well, which is essentially, in my opinion, how Medicare has become as strong as it has, even though I think there's room for improvement.
Yeah, including members of Congress. Members of Congress being on this plan provides an incentive for them to make it. And also, like with Medicare, because everyone's on it, you do get broad, strong advocacy for people who can come together and say, we need this covered, and make sure that there's some accountability there to make sure that the plan is covering people's real needs.
Mm-hmm.
Great, thank you. So our next question comes from Patricia. So what do you think of expanded Medicare for all? So including vision, dental, and naturopaths?
Mm-hmm. Yeah, I was actually reading the bill this week and I noticed that. So yeah, in terms of the improved Medicare for all, I think we definitely want to make sure that not only are more people being covered, but we're covering more things when you're on the plan, which should hopefully, address people's concern that Medicare is going to be stretched too thin. What we really want to be doing is strengthening it and expanding it. So definitely including things like dental, vision, hearing aids, things that, one would think would be covered under any plan because people need those things, but unfortunately are kind of a gap right now with coverage. I know one question came up for mental health as well, and I think that's also an area where we're seeing a lot of potential with something like a single payer system. I'm hoping to go into psychiatry once I graduate, so that's definitely something that is important to me. And I think we're seeing with COVID, the burden of this past year, that mental health is a really serious burden on not just individuals, but also the country as a whole. So having something like that covered, I think, has huge potential. In
Yeah.
terms of
Great.
naturopathy, oh, sorry, I
Yeah.
was just gonna say, I had read in the bill that they are consulting with the NIH departments of naturopathy, which I think shows that hopefully there'd be a robust research backing behind anything that would be covered under a plan, which I think would be a concern. People wouldn't want their tax dollars going towards something that's not evidence-based. But I think it's fair to say also that there's some room for us to make some strides with more natural treatments and things like that.
Yeah, and having a Medicare for All plan that allows people to get preventative care, regular primary care, not putting off, what is this bump or whatever, and not waiting too long to get it seen. All of that saves, makes the system less expensive in the long run. You can even, more broadly encourage people to do things that save money, like establish a living will, advanced care directives that can really save a lot of money for end of life care. That kind of thing could be, perhaps more easily promoted with the national healthcare program. So, yeah.
Great. Next question comes from Joe. In those countries that have socialized medicine or public funding, private delivery, are the amounts spent in those countries for private pay medical services included in the per capita numbers?
So my understanding on those numbers I showed is that that's for the whole country, the average amount spent per person. In the private sector, they're going to be spending more money because, as you can imagine, if you can get free healthcare from the public system, or you can go to the private sector, then you're going to be shelling out some money yourself, but people expect to get something really good for that money. So it's more expensive, but also, for example, might have a more luxurious room in the hospital and things like that, maybe faster access to doctors. So the numbers I showed were just the average across the country, but it's worth mentioning that the private sector in those countries is more expensive than the average.
And the profit margin will obviously wouldn't exist in publicly funded countries, but the profit margin here is astronomical, and so that's really what ups those costs by a lot as well. Cool.
Yeah,
Sorry.
and I think that they're comparing apples and apples there when they talk about per capita healthcare spending. They're talking about total spending from any source, right? Whether it's out of pocket or from the insurer or or the employer or whatnot, right?
Yep.
Great. So the next question is from Patricia. Does the bill presently on offer get rid of the 20% copay that many of us cannot afford?
Yeah, I think someone actually answered it in the chat, but as they said, there are no copays under our system. So it's all covered by taxpayer dollars, meaning if your doctor prescribes a medication, you get it without having to pay for it. I think the only exception is that if it's a name brand medication, when there's a generic available, the plan asks people to pay for that, but not the entire drug. It's capped at $200 a year. So much less than many people are spending even on their generic medications right now. And that would only be true if you requested the name brand despite there being a generic available.
Okay, so this sort of this question came up, and one way I like to couch this is in terms of when I lived abroad. But the question is, in James, would there be a private option for those who want it under Medicare for All? And Patricia asked a similar question of, wouldn't people who have private insurance still have to pay taxes that fund the Medicare for All? And when I talk to people about Medicare for All, I think health insurance is so baked into like the American psyche that people need to even live abroad and experience it in other countries to understand that what this would do is completely do away with health insurance as we know it, and it would be replaced completely by the publicly funded option. So, with that being said, how does the sort of private option and this public single payer system, how would those two work, or would they work?
Yeah, I mean, essentially, yeah, you wouldn't need private insurance because Uncle Sam would be your insurance company, and anything you needed for your healthcare, you would simply go and get it from your healthcare provider, and then the bills would be paid by Uncle Sam, is the basic idea. And there maybe could still be some kind of, like Justin was talking about, for maybe special unmedically necessary things that people may still want. There could be perhaps some high-end boutique private insurance, but those should really just be things that aren't medically necessary and more of a want than a need. But so in general, the idea is just no, everything that's medically necessary would be covered. Right,
Great.
I mean,
Yeah, no, I mean, really not too much to add. I think one great thing about having everyone on the same plan as opposed to a public option is that everyone is paying to the best of their ability based on what your tax bracket is and things like that. So there's never a concern that you're paying for a product that you're not getting, which to me is essentially how the system works right now. You might be paying taxes that go towards funding healthcare plans that you couldn't avail yourself of because you're not in the right income bracket, because you make slightly too much money over the poverty line. I think right now we're paying a lot for services that we're not getting. So actually this streamlines it and makes sure that if you're paying into the system, you also get to draw out.
Yeah, and actually, when Representative Jayapal introduced the bill last week, they included a really wonderful Medicare for All calculator, which I'll drop into the chat here, and you can essentially calculate an estimate of how much money you would save or how much your taxes would increase under this wonderful bill. So I did it for myself, and my taxes would probably go up about $800, but I would personally save about $5,000 because I wouldn't be paying, taking out of my paycheck that premium that goes, every month to a health insurance company that's administered by my boss, who at the drop of a hat can change it, and then I'm screwed over. And if my employer doesn't have to pay for my, premiums, he could pay me directly more money. So basically my premiums come to about $7,000 a year. My taxes go up by 800 possibly, and it wouldn't be dependent upon my job. If I lost my job, if another downturn happens like this or pandemic. So it really, it's a no-brainer. But that's a little a fun calculator that I just put in the chat, so everyone can give that a try. Cool. Let's get a couple more questions going in. So from Martha, exactly how does Medicare for All differ from Medicaid? And is it different for existing Medicare beneficiaries? And Brian asked a similar question about, would Medicare for All system replace Medicaid? And so he said he works in mental health care, and he knows that many of those programs rely on Medicaid funding and state cost sharing. So could the Medicare for All potentially save the state money on healthcare costs?
Yeah, so I actually had a slide about this, but unfortunately I had to take it out due to space. But yes, it would replace Medicaid. Everyone would be covered. What that means is that states wouldn't be paying into the Medicaid program, which has become a pretty big wear on state budgets. But there is a clause in the new bill saying that anything that is currently paid for by a state's Medicaid program, the federal government is obligated to continue those payments. So for example, if there were like a rehabilitation facility that's covered by Medicaid, then Medicare would be required to continue covering that as well. And my expectation is that that would also include those wraparound services that you mentioned that help facilitate people accessing that care. So in short, Medicaid would go away, but it would be replaced by this more unified and improved system.
Cool.
Yes,
Great.
and we would
Sorry.
hope to see, hope to see state taxes drop significantly. There would be some increase in, federal taxes, but state taxes should drop. And of course, your premiums would be gone and your copays would be gone. And in the end, it's a lot less money per capita, about 15, 20% less expense per capita.
So another great question, I think the last one that we'll sort of tie this all up really nicely is, what can we all do if we're not running for office, but what can we all do to help move this bill forward?
Good question. Well, in this state, we have Representative Johanna Hayes being the one candidate who supports Medicare, the one politician at the federal level who supports Medicare for all. Actually, and also Richard Blumenthal is the one senator who supports it. But Chris Murphy does not, Rosa DeLauro does not, none of the others do. And there are going to be some primary challenges in the first congressional district, right? Help me out, Sivan. Are there two running in the first district?
Yes. So we've got Mawad and Andrew Legnani, who are both primarying in the first district, and I'm not sure about the second district. But yeah, there are those primary challenges.
Yeah, those
and both of their platforms are Medicare for All.
Yeah. I mean, I wish them luck. I think that the two-party system is problematic because you are stuck with with your least unfavorite choice, and you can't really vote for the things you want to wholeheartedly. It's not as representative. And so this is why I'm spending half my time these days working on getting the state to adopt ranked choice voting so that you can rank your choices on the ballot, indicate this is my first choice, and say it's Justin, and maybe Rosa is my second choice. But then if I come in last, Rosa, your votes would go to Rosa. So at least you got to express that preference for Medicare for All on your ballot, so it appears somewhere. So, that's why I'm involved in the Green Party. And I think I encourage everybody to do everything you can to answer the question, support, talk about it. Every little thing you do, you don't know what the ripple effects are going to be. There's no action too small. Share your enthusiasm, talk about it, get it in people's minds, bring it to the attention of your legislators, and ask them if they don't support it, why not? And, if you can't change their mind, then change who's holding their seat.
Amen. And I'm going to put in a link here to find your representative. If you don't know who that is, you can look them up by your zip code. And once they show up, it includes their contact information, so you can email them, you can call them, you can write them a letter, and letting them know. Another thing that people can do is look for your local Medicare for All groups or other partnering groups, for instance, like PNHP, that advocates for this, and see how you can volunteer or sign up for their newsletter or donate to them. Another thing you can do is also donate to us again. Yay! So I'm going to put our donation link in there one last time. And we've got to show people that we really mean business. I think if COVID has shown the world anything, is that capitalism can fall in a week, and we cannot have a pandemic that makes people sick, but then they've lost their job and now they don't have health insurance. So we need to fix that as a society. And electoral work is definitely, I think, the best way to do it. But there are other advocacy groups out there that, do canvassing, door knocking, phone banking, things like that, that will also help with that. Right. And the billionaires get richer.
And including, of course, Medicare for All Connecticut, Sivan, which put a link in the chat for Medicare for All. Yeah, that you and I are members of.
Yes. Holly, what's our website? Sorry, I know everybody else's website and information in our, let me put our Facebook information in there, because I don't think our website's up and running yet. We're too busy contacting politicians to make a website. But here's the Facebook for that, and sign up to join us. We have monthly meetings, and we have a lot of exciting stuff actually coming up. So I'm sure everyone would want to be involved in that or be aware of it. Yes, and then social media for the campaign is also Justin For All, Paglino for Congress, and at Justin For All 2. So it's at Justin, the number 4, all 2. That's on Twitter. We're very proud of our number of Twitter followers. And if everyone can see on the screen here, we've got Christopher Riley, who's our treasurer, and he looks really bored right now. And so when you make a donation to the campaign, he gets really busy because he has to send emails out to everybody. So let's keep him busy.
Ladies and gentlemen, Christophers are standing by. Please pick up your phone.
Exactly. So those were really all of the questions that we had. They were fantastic questions from everybody, and I hope that we answered everything. If you have additional questions, please check out our website, which is justinforall.org. I'll put that in there. And our email is info@justinforall.org, which I'll put that in here as well. And if you have any follow-up questions or anything like that, we will certainly be happy to answer them. And so I just want to thank everyone for coming, and thank both Justins. Justin Halloran, any closing words?
Yeah, I think I'll just mention, on the topic of, how I got into this topic. As I mentioned, I got interested when my mom lost the union insurance that she had through my dad. I do think it's a fun fact to mention that my dad's union, who provides great insurance and provided insurance to me for many years, is one of the biggest supporters of Medicare for All. That's the International Board of Electrical Workers. My dad's an elevator mechanic. And so they are really invested in this topic just because it allows them to focus their negotiating power where it counts, which is providing good compensation for workers elsewhere, not just trying to provide healthcare itself. And so I just wanted to make sure I had a chance to mention that as well.
That's actually an excellent point. So if anybody here is a union member or knows union people, please, talk about this, advocate for this, because unions should be doing much more than just fighting for health insurance for you. They can be fighting for childcare options, for more pay for you, better health and safety issues at work. Literally anything else than just being an insurance broker. So if you are a union member, you are one of the strongest people out there who can really fight and get this passed. I mean, if you look at Bernie Sanders and the Nevada primary, it was union workers who got him over that threshold. So sorry, I just had to chime in with that. Justin.
Yeah, and I think that I think this may be a topic where unions and their employing companies could agree in many cases, because Medicare for All is something that could really save money for a lot of businesses. Paying for their employees' healthcare costs is an extremely expensive burden, and they would still be picking up some of the cost, but depending how you balance that, I think we could really skew this more. My preference would be to really skew it more towards being funded by a progressive income tax on individuals. And I think, they would, and it should be progressive. It shouldn't be, the burden shouldn't be on lower income earners. It should be higher, you pay, the more you can afford to pay, the more you pay. But I think it would be relief on so many businesses, as well as their employees, and not to mention states and municipalities and all their healthcare costs. It's just amazing to think of, what freeing up all that money could do to help employers, afford better other benefits for their employees, and help municipalities get by, and states.
And afford better employees too, because who are you as an employee going to go work for? Google, or the guy down the block who can't provide you with the same benefits. So it makes small businesses, which is again the backbone of America, more competitive. Excellent. So Justin Paglino, do you have any closing remarks?
I want to thank everybody for coming, and I want to thank you, Sivan, for organizing this event. And I want to thank Justin for that. I really appreciate your being here and giving that talk. I think people are, it's very informative and people are very impressed. And I really do appreciate any support that folks can give to our campaign. We are getting an early start, and we're deadly serious about this. I've demonstrated that I'm willing to do this, and I'm serious about taking on Rosa as a politician who doesn't support Medicare for All. And there's other issues in the campaign as well, but this is really first and foremost and close to my heart. So, and thanks to everybody here. Chris is my treasurer. Louise is working on social media. And Holly, we're going to be on the radio soon. Is that right?
Yes, we are. Monday, April 5th at 11 a.m., 103.5.
Yes, we're going to be on, there's going to be a radio show featuring the topic of Medicare for All.
Correct, yes. And I hope Justin will join us as well. I'm gathering questions. Are you available?
You said it's April 5th at what time?
11 a.m.
What day of the week is that?
Monday.
All right, yeah, let's do it.
Yay!
Okay.
Look at us.
So I have a lot of questions coming in from my Mothers and Others for Justice group. So they're going to send in a lot of questions that are coming from the community. I thought that would be a really good way to talk about the topic. Not just, speak and, take the questions. So I think that's how the format's going to go.
Yeah, it's great. I mean, no one of us can do this alone. We're all trying together. Every action you do is a positive action. And so thank you, everybody, for whatever you do. Go fight, win.
Yes. Thank you, everyone. And also to say there, please sign up, on our website, on the justinforall.org website for our newsletter, because we have a ton of upcoming events, including the radio show that Holly mentioned. We'll also have a day of action on April 3rd, where our main event will be demonstrating in front of Rosa DeLaura's New Haven offices. We'll do that socially distanced and safe, but we really got to show her that this is what 70% of America wants, and she's got to give. So that being said, thank you so much to everybody for coming. We couldn't be more grateful for you being here and supplying the fantastic questions for tonight. This was really fun. Thank you, Justin, and thank you, Justin. And we will see everybody next time. And don't forget to donate.
Thank you.
Thank you.
Thanks.
Good night, everybody. It was nice
Have
to
a good
see
night.
everyone. Good night.